Hi, everyone.
Hi, Kangsha. How are you?
Good. How are you?
Hello, Courtney.
Hello. Okay. Today is just a meeting session. Can you hear me? Hi.
Yeah, we can hear you. I can hear you.
Good, good. Okay. So disclaimer, I haven't read the article, so I will be as dumb as those who haven't read the article. Those who have read the article, just enlighten us. That will be great. I kept this session so that I get motivated to read it.
Yeah, I know. Good idea.
Yeah, with the busy lives we have, it becomes hard, sometimes challenging to read stuff. So, Nupur, are you getting the? I made you co-host.
Yeah, I'm getting that and I'm admitting them.
Okay, good. Okay, that's good. And then there was a article that Iman had shared in the group earlier. Apparently, he kind of highlighted stuff from the last session. See.
So what did you all do in the last session?
No, we just read up till before marginal zone, I think, and then we just like summarize stuff and stuff like that. Nothing. This is international, okay. WHO. Nothing big. We are going to summarize this again because the last session was not recorded.
Right.
And,
yeah. That would be good.
Yeah, yeah. So like at least summarize it in quickly in 10 minutes if we could.
Yeah.
So, yeah. Where is Iman's document?
It's the one that the name is file. It's like, I think, previous one. Top. Sorry, I just.
File, this one?
Yeah, this one.
Oh, okay. Okay. So let's quickly revise what we read in the last session. You guys ready?
Yes, go ahead, please.
Okay. So there has been a lot of history to WHO classifications. Previously, we used to have real classification, international lymphoma study group classifications, a lot of other classifications as well. And then it all came into one net of WHO classification. And then the WHO 4 revised, or 4R was the previous classification that we had. Now we have IARC have a new classification as WHO Heme 5 in 2018. I have a question here. So, the most recent articles that are going around are these WHO and the International Consensus Classification. Which one are we going to follow in US? Does anyone know that?
No, it's a good question, actually. We need to look it up and ask it.
Yeah, I mean, I think we need to study both the articles so that we are updated with both the things. But I don't know which one we are going to follow in our practice.
Yeah, I think we were having this discussion in our department as well, because it's going to be so confusing for the clinicians. So yeah, but I don't think so far we know which one we are going to follow, but probably maybe WHO, just because WHO is, like
has been forever, yeah.
Yeah.
Yeah, and because I mean the WHO is IARC is more of Europe, France, and stuff like that, right? And the international consensus classification, the authors, they are more US based. I saw like the main authors and stuff like that, they're US based. So I was like, okay, I don't know what's going to happen. Like we have to have one ground here.
Correct. Yeah.
Anyways, so now it is called as WHO Heme 5. And they started in 2018 apparently, and then they did a lot of hard work. They just in the initial things, they mentioned that they were like how many people came together, and virtually they came together, and then they did all of the right things to make this WHO Heme 5 the best thing ever. And so then so yeah, now this is important. So now in WHO 5, this was not present in WHO 4. I don't know if I want to not have the admits button. Can I do that? I don't know. I'll have to each time.
I don't think you can do that. You're the host. You're going to get that notification, but I'll admit them, so don't worry about that.
But do you guys see this thing every time, like the black thing?
We are not seeing a black thing. I get a pop-up saying so and so is in the waiting room, and then I admit them.
Okay, but you're not seeing that pop-up that I am getting, right? The black pop-up.
No.
Okay.
At least I'm not.
Okay, good. Okay. Yeah, so this
I
is a
don't
new
get it
thing.
either.
Okay, good. Okay, so this is a new thing that is in WHO Heme 5 that they are now going from low like indolent to aggressive, and all of their classification basically is based on the first things that they are discussing, and the first things in the classification are the indolent things, and eventually they go to more and more aggressive. And then there is another thing that they have essential and diagnostic criteria and desirable criteria. So essential criteria, like previously we used to have these kind of major and minor criteria as well. So we used to have 3 major, 1 minor, or 4 major and stuff like that. Now we have essential criteria, so all the essential criteria together, and then the desirable diagnostic criteria. So that's that. And then let's see what else he has highlighted.
So is that just a nomenclature difference, or for replacing it from major and minor, or have they moved criteria away from like minor to maybe essential?
As we go forward, we will know if there are any major and minor criteria.
Yeah, my understanding was essential is the minimum criteria, and
Right.
desirable is like some institute, like they do like extensive molecular and like IHC panels. So that's the desirable. That was my understanding.
Gotcha. Okay.
Right. And some of the classification, like some of the nomenclature itself is based on the molecular. So if you are going to name it as that, then definitely those molecular become the essential criteria too, right? So we'll read, I mean, as we go forward with the classification and everything, we'll read what exactly they mean by essential and desirable criteria. Okay. And then, so yeah, now they have, they obviously, like any WHO, new entities are created, and then names of the entities are changed, and the subtypes of the things are changed. So now they are saying novel potential subtypes have been restrictively proposed in some entities, such as in Burkitt lymphoma, where besides 3 traditional epidemiological variant, the distinction of EBV positive and EBV negative Burkitt lymphoma is recommended. And order of classification follows traditional major. Can you guys see this? It's a little. Let me.
Yeah, I see it. It's a little bit like hazy, but it's.
Yeah. I don't know why it's doing that, but that's okay.
I think it's because the pen I used to highlight it. That's because of that.
Okay,
that's okay. We can still read it.
Yeah. That's why I made it bigger. So the order of classification follows traditional major subgrouping according to cell lineage, with precursor cell neoplasm followed by mature. So obviously that's what previously used to happen as well. Within a family, the entities are arranged in the order commencing with more indolent, progressive to increasingly aggressive ones. So that we saw. And then so coming to the B cell proliferations and lymphoid, now they have added a tumor. So let me go into that chart, and it will be first revise from here. So now this is the chart that is in the next page if you guys are following the article side by side. So this chart has the basic classification, and now they have added tumor-like lesions with B-cell predominance, which has 5 categories. And these 5 categories include 3 categories of Castleman, 1 category of IgG4, and the 1 category of reactive B-cell lymphoid proliferations, which we'll see what comes into that. So again, Castleman is unicentric, idiopathic multicentric, and they have HHV8 associated or KHSV/HHV8 associated. Now they are adding KHSV everywhere, apparently. So KHSV, HHV associated multicentric Castleman. And then IgG4 related comes under tumor-like lesions with B-cell predominance, and reactive B-cell rich lymphoid proliferation that can mimic lymphoma. So amongst these, this HHV8 was previously classified as multicentric Castleman's disease, and these all entities were not present. Even the tumor-like lesions with B-cell predominance was not an entity previously in the WHO. So that's that. Coming to the precursor B-cell neoplasms. So they have NOS, which is the same BALL NOS. Then they had these specific entities as previously. However, they have changed the nomenclature of some of them. So now they are calling the hyperdiploidy type, like the BALL with hyperdiploidy, which was previously called as just hyperdiploidy. Now it is called as high hyperdiploidy. And apparently, I mean, with their discussions previously, the definitions are still the same, more than 50 or something, more than 51 or something, if I remember it correctly. But we'll have to see when we are reading why they are calling it just high hyperdiploidy versus hyperdiploidy. So because in hypodiploidy, they used to have 3 categories, apparently low hypodiploidy and stuff like that. And in hyperdiploidy, they didn't have 3 categories like they had to used to have in hypodiploidy. So that's something that they added. And then B-cell lymphoma leukemia with BCR-ABL fusion. So instead of calling it the whole thing, translocation 922 and the translocation partners and the BCR-ABL one, now they are using, one thing to remember is they're using 2 colon marks for this. They're italicizing this, and they're BCR 2 colons ABL 1. So they have moved from the cytogenetic like nomenclatures. So they are not using any of these. They are not. Suppose, can you mute someone who is there?
Yeah, I'll do it.
Yeah. So they are not using these cytogenetic nomenclatures. They are directly going towards molecular. And so again, BCR-ABL fusion, and then BCR-ABL like that was previously. Now they are changing to BCR colon ABL like, and again italicized. And italicized was previously there as well. KMT2A, that was translocation V11, now became just KMT2A rearrangement. It was rearranged before, it is rearrangement now. ETV6 runs 1 again, so without the cytogenetic things, the ETV6 colon that runs 1. This entity ETV6 rungs 1 like was not previously included. Now they have included the ETV6 rungs 1 like. This another entity PBX1 was already there, and IGH IL3 was already there. Now they just went to the molecular things, and then this TCF3 HLF fusion, this was not previously included. Apparently, this is more aggressive form of BALL, and that's why they had to separate it out and as more aggressive form. And then other defined genetic abnormalities are the same. So that's about the precursor BALL. Coming to mature BALL, the monoclonal B-cell lymphocytosis is the same. CLL, SLL is the same. Important and very important thing, historically, prolymphocytic leukemia has been a pain, and has been a pain not even for younger generation, has been a pain for even for the more experienced generation. The criterias were more than 55% prolymphocytes, and people used to have a lot of caution before calling up anything prolymphocytic leukemia. Now, this entity they have completely deleted, and this entity is going to come into splenic B-cell lymphoma leukemia with prominent nucleoli. And then another thing is that there was a entity called as chronic lymphocytic leukemia, small lymphocytic lymphoma with progression or with prolymphocytic progression, something like that, or prolymphocytic transformation, something like that. And now they apparently have that still in the CLL SLL. Is that correct? That we had discussion last time. And the more than 55 prolymphocytes, or even more than 15 prolymphocytes, have gone into the splenic B-cell lymphoma leukemia with prominent nucleoli. And so hairy cell is the same, marginal, so splenic marginal zone is the same, diffuse red pulp is the same. And then this entity, this was not previously included. Now they have included this entity, splenic B-cell lymphoma leukemia with prominent nucleoli. And this entity, it has, the hairy cell leukemia variant is no longer a term. They are not using a hairy cell leukemia variant. Similar to B-cell prolymphocytic leukemia, it is now encompassing into the splenic B-cell lymphoma leukemia with prominent nucleoli. So that's that. LPL is the same, marginal zone is the same, extranodal marginal zone is the same. Primary cutaneous marginal zone was not previously included. Now, originally it was under the extranodal marginal zone of MALT. Now it is separated out as primary cutaneous marginal zone. And then the others as the nodal marginal zone and pediatric marginal zone. So those are the same. In the follicular lymphoma, they have minor change of terminology. In situ follicular neoplasia, they have changed into in situ follicular B-cell neoplasm. And the rest, follicular lymphoma, pediatric type, duodenal type is the same. Primary cutaneous is the same, follicular center lymphoma. Again, in situ mantle cell neoplasia became in situ mantle cell neoplasm. I wonder why they didn't use it uniformly and made it in situ mantle cell B-cell neoplasm, but okay, whatever they wanted to do. And then mantle cell lymphoma, leukemic non-nodal is the same. And now there is another category, which is called as transformations of indolent B-cell lymphomas. And this was not included before. So previously we used to call CLL transformation as Dick-Richter's transformation. There used to be DLBCL or follicular transformation into large B-cell lymphoma and stuff like that. Now they are all coming into one bracket, that is transformation of indolent B-cell lymphomas. So that's that. Large B-cell lymphoma. So diffuse large B-cell lymphoma and T-cell histiocyte-rich large B-cell lymphoma are the same. This nomenclature, it was originally, when they made it, it was a little confusing. And now they have got away from the complete nomenclature. It was previously MYC and BCL2 and or BCL6 rearrangements. And now they are removing BCL6 from it, and they are all calling it diffuse. And now they're calling it DLBCL / because I mean, that time maybe it was not very clear that they didn't used to call it DLBCL. They used to call it high-grade B-cell lymphoma with MYC and BCL2 BCL6. Now they are calling it DLBCL / high-grade B-cell lymphoma, and there are only two partners, MYC and BCL2. So they have removed the BCL6 from here. And then ALK positive large B-cell lymphoma is the same. Large B-cell with IRF4 is the same. Burkitt lymphoma with 11q aberration, that was previously an entity. Now they are calling it high-grade B-cell lymphoma with 11q aberrations. Apparently, there might be other partners with 11q that are high-grade and not Burkitt-like. So we'll see why they are calling that. Lymphomatoid granulomatosis is the same. EBV positive DLBCL NOS now became the NOS they removed. They said EBV positive DLBCL. DLBCL with chronic inflammation is the same. They have added, previously this was considered of the subtype of diffuse large B-cell lymphoma associated with chronic inflammation. And now they are calling it like they're separating out the. Say again. Nipur, can you mute? There's someone.
Yeah, I'm muted.
Okay, thank you. So now they have separated out a fibrin-associated large B-cell lymphoma as separate entity. This was previously under chronic inflammation itself, but now they are separating it out. There was not this fluid overload associated B-cell lymphoma is an entity that has been added, and plasmablastic is the same. And then this primary B-cell lymphoma of immune privileged site was not there. It was actually in the so this entity of immune privileged site, it was as primary diffuse large B-cell lymphoma of the CNS, and this entity has been now engulfed by the immune privileged site's name. And also large B-cell lymphoma of the vitreoretina and primary large B-cell lymphoma of the testis are the two things that are going to be included in this entity. So immune privileged sites. Leg type is the same, intravascular is the same, pre-MBL is the same. Mediastinal. So mediastinal, they basically complicated the nomenclature last time, and they don't like it this time. So previously, the last time they called it unclassifiable with features intermediate between DLBCL and classical Hodgkin's. Apparently, they don't like this classification anymore, and they fall back into previous thing. They are now calling it mediastinal gray zone lymphoma. And high-grade B-cell lymphoma NOS is no longer, it's the same, sorry. And then Burkitt is the same, primary effusion is the same. Now, as I was mentioning that they're adding KHSV to the HHV8 things, positive things. So the HHV8 positive DLBCL NOS, they removed the NOS from there, and they added a KHSV8. So KHSV8, HHV8 positive DLBCL. Germinotrophic, again, it was a germinotrophic lymphoproliferative disorder, HHV8 positive. It is now a KSHV positive, KHSV/HHV8 positive. I mean, these are the terminologies that are helpful for those times when we are going to, like top line the things. Though this is when we have to change our nomenclature. Top line, or even mention in the comments if we are not sure. Lymphoid proliferations and lymphoma associated with immune deficiency and dysregulation. So they added multiple entities in here. So first they added was hyperplasia arising in immune deficiency and dysregulation. So it was not previously there, and this hyperplasia, it encompassed the non-destructive post-transplant lymphoproliferative disorders. So, I mean, they have gone away from some nomenclatures that were previously there, and now they are calling it hyperplasias arising in the immune deficiency or dysregulation. Now, again, polymorphic LPD arising in immune deficiency and dysregulation. It now encompasses the polymorphic post-transplant lymphoproliferative, other iatrogenic immunodeficiency associated. So those two, polymorphic post-transplant and immunodeficiency associated, those are in the immune deficiency / dysregulation. ABV positive mucocutaneous ulcer is the same. This one, lymphomas arising in immune deficiency / dysregulation. So, so the immune deficiency dysregulation remains the same, apparently. First is hyperplasia arising, second is polymorphic LPD arising, and third is lymphoma arising. And the lymphomas are arising, they apparently include the monomorphic PTLD and CHL, and lymphomas associated with HIV infection. So that's that. And then inborn errors of immunity-associated proliferations and lymphomas. So this was previously lymphoproliferative diseases associated with primary immune disorders. Now they changed the nomenclature to inborn errors of immunity-associated lymphoid proliferations and lymphomas. So that's about it. No, there is CHL, but CHL we can read later as well. Yeah, CHL we can read while we are doing the CHL. So this is about the B cell changes in a summary. And going back to our B cell new defined, okay, here. So that's where we left. Tumor-like lesions with B-cell predominance, as I was mentioning, has 3 Castlemans. So unicentric Castlemans, idiopathic multicentric Castlemans, and KHSV/HHV8 associated multicentric Castlemans. So these 3 plus there are 2 more IgG4 related. So that IgG4 related, they are saying that IgG4 related lymphadenopathy has features that overlap with the Castleman's disease. And then the 5th one is non-neoplastic B-cell predominant lymphoid proliferations. So these non-neoplastic involving the nodes and extranodal sites, and they apparently are the PTGCs, infectious mononucleosis, florid reactive lymphoid hyperplasia and lymphoma-like lesion of the female genital tract, and SLE. So in this category, like they have 5 categories inside, and in this category, non-neoplastic B-cell predominant lymphoid proliferations involving lymph node and extranodal sites. There is PTGC, infectious mononucleosis, reactive lymphoid hyperplasia or lymphoma-like lesion of the FGT, and SLE. Coming to BALL, similar to what we said, they're not going to say anything different here. So BALL can be diagnosed at family class level on morphology. Yeah, so this is important. Now, if you have just morphology and immunophenotype, then you're going to call it BALL not further classified. So it is BALL NFC. If you just have morphology and immunophenotype, and if you have now the other things, so for example, the cytogenetic, molecular genetic testing and everything, so that now becomes the current state of art, and that's why they have the entity specific to those molecular changes. And so if after the comprehensive testing of cytogenetic and molecular and everything, if you can't find anything and it cannot be lumped into a category, then you are going to call it BALL-NOS. So before morphology, before just with immunohistochemistry, BALL not further classified. So this will be your top line for most of the cases that you're going to say that the molecular and cytogenetics are pending. And once the molecular and cytogenetics are back, if it does not go into any category, you're going to call it BALL-NOS. Polyploidy changes, again, the hyperdiploidy, they have gone into high hyperdiploidy, and that's that. Then the well-known drivers, as we read, IMP21, BCR2:ABL1, KMT2A rearrangement, and ETV6 RUNX1, TCF3 PBX1, and IGH3L3. So these were there in the previous classification, all of that. They changed the nomenclature, but they were there. They have added a few. So those added ones include HLF. So TCF3 PBX1 was there previously. Now they have added TCF3 HLF. Distinct entities characterized by particularly aggressive behavior. And so now the previous provisional entity of BCR-ABL-like, BLL with BCR-ABL-like features, now they are making it a real entity, and that will have gene expression and phenotypic features of BCR-ABL1 fusion, and is prevalent across all ages. Okay, and then BALL ETV RUNX1 like has been added as an entity, and the description which follows the section on BALL RUNX1. Okay, so we'll read. So that's that, and so CHL we'll do eventually. So now BALL with DUX4, MEF2D, ZNF34, NUTMA1, IG, MIC, and all of those are still under considerations. Potential future, they might be potential novel entities that might be incoming. And then this thing, the minor thing that I don't know if boards will like to ask, but some minor trivial thing is that PAX5, DUX4 rearrangement or PAX5 rearrangement, PATR will have monocytic differentiation. So that's that. MBL. So MBL, we had a good discussion on MBL. There are a few things in MBL that have to be considered. And first thing is, if it is a CLL-like phenotype, any MBL with CLL-like phenotype is classified into two categories. First is low count MBL or clonal B cell expansion. So that will be less than 0.5 of the clonal CLL B cell count. And remember, it is clonal CLL B cell count and not the total lymphocyte count. And then CLL, SLL, MBL, CLL, SLL type, which have the usual, that is more than 5. More than 0.5 and less than 5. And more than 5 is obviously CLL, SLL. So again, less than 0.5 is low count MBL or clonal B cell expansion, and CLL, SLL type MBL is 0.5 to 5 clonal CLLs, clonal B cells, and then non-CLL SLL type MBL. So any monoclonal non-CLL phenotype B cell expansion. So basically, if it is less than 0.5 and non-CLL type, you're not going to call it low count, low count. Yes, you're going to lump it into this category, non-CLL SLL type. Period. So any monoclonal non-CLL SLL phenotype with no symptoms or features diagnostic of other mature B cell neoplasms, you're going to call it non-CLL SLL type MBL. They apparently haven't given less than 5, but I would assume that they mean less than 5 in this one. I mean, given that more than 5 is still considered SLL, CLL. I don't know if they have the previous provisional entity of a typical CLL, SLL. There might still be there. Anyways, so now they mentioned that in the diagnosis of CLL, CD5, 19, 20, 23, surface kappa lambda are regarded as the essential markers, and the others, CD10, 43. So basically these all labs, whether it is institutional, major academic centers or private labs, all of the labs have these basic essential markers. Then some of the academic centers like MSK used to have ROR1. Some of the academic centers have established the other panel for CLL as well. So these include CD10, 43, 79B, 81, CD200. We used to have 200 as well. I think we had 81 as well, but I'm not sure. But these are the entities, these are the markers, additional markers. Many private labs have not yet have not, like they have established CD200, but they have not yet established ROR1. But these are the additional markers that can be useful in the differential diagnosis of SLL, BLL, SLL, CLL. And now, in addition to, so we used to do all of these in CLL, SLL. We used to see the cytogenetics and the others. So basically, DELF 11q, 13q, 17p, trisomy 12, TP53, IGHV. All of these are prognostically important. So now, these become all essential. They are all essential for the full prognostic evaluation. So again, if you have CLL, they're recommending that these are all essential for the prognostication of the CLL. And then detection of karyotypic complexity, BTK, PLCG2, and BCL2 mutation status. These are desirable. So karyotypic complexity, BTK, PLCG2, and BCL2 mutation status. Now, the IGHV mutation and TP53 aberration status are included in CLL International Prognostic Index. And then we know that it has multiple things like age, clinical stage, beta-2 microglobulin, and stuff like that. Then there is another one, international prognostic score for early stage CLL, SLL. We don't need to remember all of this. This is more of, I don't think we need to like go into much detail of that unless you are really interested into. Okay. And then, yeah, so Richter's transformation, what they are talking about that. In the setting of transformation, use of the term Richter's transformation is recommended over Richter's syndrome. So they are still calling it Richter's transformation apparently. And we used to call it Richter's syndrome sometimes. Many of people were already calling it Richter's transformation. So they are using the term Richter's transformation over Richter's syndrome. BPLL, important thing. So the BPLL, they mentioned one thing which I am still having confusion with. So they used to say, they said that the cases that have been labeled as BPLL include a variant of mantle cell categorized by presence of IGH CCND1. That we already know. That the BPLL is similar, the immunophenotype is similar to mantle cell, in that it is CD5 positive and stuff like that. And it has IGH CCND1, presence of IGH CCND1. Another thing that they said that BPLL were also labeled when the prolymphocytic progression of CLL was there, defined by more than 15 prolymphocytes in the peripheral blood or bone marrow. In the previous WHO book, they clearly mentioned that this entity should not be classified as prolymphocytic leukemia. And apparently there must be some confusion or between this entity. Yeah, go ahead.
I just went through these references which they have given 44 to 47. So these are like really old references from 70s, 80s, and 90s. So probably in those articles, they have classified them as that. And now they are saying that these are now called this splenic B-cell lymphoma with prominent nucleoli.
Right. I mean, if they're talking about changes from WHO4R to WHO5, then this is not relevant. Because WHO4R already excluded the CLL, like prolymphocytic progression of CLL from the prolymphocytic leukemia, right?
Yes, that's what I was telling, that these are references are from the old publications, from like really old, 40, 50 years back. Yeah.
Right. And then, so now the whole BPLL category is now classified as splenic B-cell lymphoma leukemia with prominent nucleoli. Now, there is another thing that they made it a little confusing over here. The CLL, SLL, with more than 15% prolymphocytes, they are still calling it as prolymphocytic progression of CLL. They are not calling it as splenic B-cell lymphoma leukemia with prominent nucleoli. So over here, they made another confusion that they said that these two entities are now classified as B-cell lymphoma leukemia with prominent nucleoli. They should ideally have not included the number 2 at all. So this is a separate category still. It is not under prominent nucleoli. So that was cleared in the previous session, that we'll come to this, that what encompasses in the prominent nucleoli and what does not. So that's that. And then splenic B-cell lymphoma leukemia, the term splenic B-cell lymphoma leukemia with prominent nucleoli is replacing the hairy cell leukemia variant and the CD5 negative prolymphocytic leukemia. So one thing, remember that the prominent nucleoli is encompassing the CD5 positive B-cell prolymphocytic as well as CD5 negative prolymphocytic. So that's that. And hairy cell leukemia variant has been engulfed by this category as well. So previously we used to have So now the B-cell leukemia lymphoma family in Heme 5 includes a hairy cell leukemia, and then splenic B-cell lymphoma and leukemia with prominent nucleoli, splenic diffuse red pulp, and splenic marginal zone. So 4 things. And previously, the splenic B cell prominent nucleoli and splenic, so the diffuse red pulp, they have been separated, and then the diffuse red pulp. And then. So now the hairy cell leukemia will have, like obviously like before, distinctive clinical pathological features and a BRAF V600E in more than 95% of the cases. And the other small B cell, splenic small B cell lymphomas will lack BRAF. The prominent nucleoli, they are discussing more here. So they have replaced the hairy cell leukemia variant categories in recognition that this proliferation is biologically distinct from hairy cell leukemia. Although leukemic cells may partly resemble hairy cells, but actually this was very different immunophenotypically in the other ways. So that makes sense. And so now this entity are also engulfing all the CD5 negative B cell prolymphocytic leukemia per the WHOR. Although data from literature cannot be extrapolated to new class, it can be stated as the prominent nucleoli is rare. So basically this entity is still anyways rare, and this will be 0.4% of your all chronic lymphoid malignancies. So this prominent nucleoli category, they will be negative for the hairy cell markers. So CD25, like this was the original hairy cell leukemia, these variant, that the variant was very different and it was negative for the hairy cell markers. Similarly, this prominent nucleoli is negative for 25 and XNA1 trap and CD123. And prominent nucleoli obviously is more aggressive than hairy cell leukemia. It basically encompassing the aggressive entities anyways, that it is prolymphocytic leukemia and hairy cell leukemia variant. So it is more aggressive. It is resistant to the cladribine treatment. And then diffuse red pulp. The diffuse red pulp has features overlapping between the hairy cell and the splenic B cell with prominent nucleoli. So they added this thing. I don't know if it was present in the previous WHO. I have to see that, but apparently, I mean, in our book, the ISMAPATH book, we didn't add this criteria. So I don't know if it was there in real WHO. Someone can check. But CD200 mean fluorescence intensity, that is MFI of CD200 by CD180 MFI ratio of less than 0.5 on flow cytometry favors a diagnosis of diffuse red pulp over hairy cell, marginal zone, and splenic B cell with prominent nucleoli. So that is a small, not small, but important finding. So, I mean, those labs who are actually doing CD200 versus CD180 MFI ratio, I don't think private labs will be doing this anytime soon. But those academic institutions that are doing CD200 versus CD180 MFI ratio, if it is less than 0.5, you can separate the category of diffuse red pulp over him. And then, so these entities can be best discriminated by pathological examination of the spleen. In absence of the splenectomy specimen, bone marrow examination shows classical features. So the bone marrow of splenic diffuse red pulp lymphoma have prominently intrasinusoidal pattern. In the absence of splenectomy, you can tell by the intrasinusoidal pattern that it could be diffuse red pulp. And the splenic marginal zone and the prominent nucleoli have a more diffuse growth pattern in the bone marrow. So if you don't have splenic, like usually the pathologic examination of the spleen will be the one that will be triumphing to categorize between these three. But if you have a splenectomy done, if you just have the bone marrow, then go for see if there is an intrasinusoidal, then favor a diffuse red pulp. And if it is a diffuse growth pattern, then favor splenic marginal zone and prominent nucleoli. And hairy cell leukemia shows diffuse along with the reticular fibrosis. So that's another thing that will help you. In absence of splenic, however, distinction is not possible. So you can only favor, you can, that's all that you can do. It's not completely possible to distinguish them. Now the LPL. So LPL they have two subtypes. So they have two subtypes. Now, LPL Waldenstrom's macroglobulinemia type and the non-Waldenstrom's macroglobulinemia type. So the Waldenstrom's macroglobulinemia type, so the non-Waldenstrom's, they're saying that it represents 5% of LPL, and those will be the cases with IgG, IgA, or else non-secretory, and IgM LPL without bone marrow involvement. So if there is no bone marrow, then also you're not going to call it Waldenstrom's. And then the other one is Waldenstrom's type. And then two molecular subsets. So the one is that has presence of MyD88, and the other one which has absence of MyD88. Apparently, MyD88 will be present in more than 90% of the LPLs. Demonstration of, just a second. Huh? Okay. Demonstration of MyD88 LP265P. Mutations may aid in differential diagnosis of nodal and extranodal with plasmacytoid differentiation and plasma cell myeloma. So yeah, it has been historically used, MyD88 very well. It is being used now again. So this is a very nice representation that they have. So previously in 4R, the hairy cell leukemia is not touched. It is still hairy cell leukemia, nothing has been touched. Now splenic marginal zone. The splenic marginal zone encompasses the splenic marginal zone as well as the splenic lymphoma leukemia with prominent nucleoli. The splenic lymphoma leukemia with prominent nucleoli, if there are prominent nucleoli in the marginal zone, or splenic diffuse red pulp, B-cell lymphoma leukemia, and hairy cell leukemia variant. So one thing to, just the marginal zone with prominent nucleoli, hairy cell leukemia variant, and prolymphocytic leukemia. These three come under, so if you see over here, the marginal zone goes over here, hairy cell leukemia variant goes over here, and the prolymphocytic leukemia goes over here. So this is engulfing these three categories. The splenic diffuse red pulp is still there, and it is the same thing, splenic diffuse red pulp B-cell lymphoma leukemia. Prolymphocytic, now it is categorized as prominent nucleoli entity. The previously included mantle cell lymphoma with more prominent nucleoli are going to be engulfed by mantle cell lymphoma itself. And the prolymphocytic leukemia that were hard to classify from prolymphocytic progression of CLL, now they are going back to prolymphocytic progression of CLL. I mean, the CLL, SLL with more than 15 prolymphocytes are still prolymphocytic progression of CLL. So that's that. And so this is what we did till last time, and we took a lot of time to summarize everything, but it was good that we summarized, because it is good to like enhance our memory like that. Any questions so far with the previous one?
Hey, Akansha, I had one question. So about the lymphoma in immune deficiency state, and where they have included a monomorphic PTLD and some other things. So then have the PTLD classification also changed?
Yes, the Pdlt classification has changed apparently. Previously, the PTLDs, they were monomorphic, polymorphic, and there were other PTLDs as well, which was non-neoplastic, right? So now they have removed the PTLD like classification entirely, and they are now, where did it go? They are now calling it separately as separate entities. Where did it go?
So the monomorphic will no longer be PTLD?
No, it will be PTLD, but it will be lymphoma-like. So they have included lymphoma-like, they have included non-neoplastic, something like that.
Hodgkin, something they've included.
Yeah, so where is that? Here. नहीं, कहाँ गया? कौन से पेज में है?
Yeah, it's in the main classification of lymphoid proliferation, I think.
Oh, I'm in T right now, actually. Yeah. So they have now different categories for that here. So now they have hyperplasias arising in immune deficiency. They have polymorphic LPD, that arising in immune deficiency. They have lymphomas arising in immune deficiency. And then, so basically the previous PTLDs that were there, so basically there were like non-destructive PTLDs, there were like polymorphic PTLDs and monomorphic PTLDs. The monomorphic PTLDs or CHL and the others, they have gone directly to lymphomas arising in immune deficiency. And then the polymorphic has gone into polymorphic with immune deficiency and regulation. And those that were non-destructive type, they are gone into hyperplasias. So basically the PTLD word, actually they have completely removed.
Correct. Yeah.
So yes. So basically they are just calling it immune deficiency dysregulation.
Yeah. I think I like that because the EBV positive mucocutaneous ulcer earlier was not kept in PTLD. It was so much confusing whether to call it as non-destructive versus this. So I think that they've encompassed everything in this entity now. I like that idea.
Right. Okay, any other things to ponder about? Okay. All right. So let's go forward now. So we were going to start from marginal zone. So marginal zone lymphoma, cytogenetic and mutational. So we are just going to read and we are going to discuss some things we are not going to understand, and then some people will make it easier for us. So let's see how it goes. Marginal zone lymphomas, cytogenetic and mutational profiles differ by anatomic site, and cutaneous marginal zone lymphomas achieve independence. So, so now they are classifying they are saying that the cytogenetic and mutational profiles, they are different based on the anatomic site. And now the cutaneous marginal zone is a separate entity. Extranodal marginal zone of mucosa-associated lymphoid tissue and nodal marginal zone will be different. That was featured as distinct entities in 4R are retained. So they are the same as in 5R, in 5. Now, so the pediatrics marginal zone, nodal marginal zone lymphoma and NMZL is upgraded from a subtype under nodal marginal zone to a separate entity. So pediatric nodal marginal zone is a separate entity. Although it allows overlapping features between pediatric type follicular lymphoma, current published evidence is considered insufficient to group these two indolent pediatric diseases into one family at this time. Primary cutaneous marginal zone lymphoma has also been designated as separate entity in Heme 5, owing to its, what the hell? Okay, so pediatric nodal marginal zone, as compared to the subtype of nodal marginal zone, it is a separate entity, and then cutaneous marginal zone has independence, and then the third one, yeah, primary cutaneous has separate. So then the extranodal marginal zone, nodal marginal zone, and primary cutaneous marginal zone have overlapping histologic and immunophenotypic features. The neoplastic cells are mature small B cells. Typically, they will be negative for 5 and 10. Plasmacytic differentiation is common, and so plasmacytic differentiation is common. Associated with reactive lymphoid follicles are also present. However, despite some shared features, they have different etiologies and pathogenesis, with further differences between extranodal arising in different extra anatomic sites. So now they are discussing what differences are there. Trisomy chromosome 3 and 18 are common. Gains of 2p and 6p and loss of 1p and 6q are frequent in the nodal. However, gains of 6p and loss of 6q are recurrently seen only in extranodal margin of ocular. Translocation of MALT1 resulting in BIRC3 and MALT1 fusion. So these might look non-important to you, but these are actually important for your board's purposes if you are giving heme boards or even your search board like AP boards. They ask you this thing. The 1118 is seen in gastric and pulmonary, and they ask you the minor detail that gain of 6p and loss of 6q and other things. So basically these are important. And in contrast, no recurrent gene fusions or rearrangement as described in primary cutaneous and nodal. Mutational profile of extranodal and nodal differ. In addition, there are significant genetic differences among extranodal arising in different anatomic sites. So these are again, ocular adnexal commonly shows TNF-AIP. I mean, I don't know why they like these things, but they do. And salivary gland, that shows GRP34. Shows recently mutated GRP34. Most thyroid EMZLs carry mutations of CD274, TNFRSF14, and TET2. Primary cutaneous will have FAS mutations and somatic variants of KMT2D and PTPRD and NOSH2, KLF2, and others are frequent in nodal marginal zone, and but not in EMZL. Better definition of underlying molecular genetics. Okay, so now coming to the follicular lymphoma. One of you will have to. So what we'll do going forward is every 15 minutes or some time when we finish a new topic, we are going to summarize everything. You have everything highlighted over here, just read from here, but summarize what we read in last. So one of you take that responsibility of summarizing things, okay?
Just FYI, Nidhi is also here.
Arey! Our professional summarizer is here. Hi, Nidhi.
Hi.
You were going to move, and no, you were going somewhere else, right? You were.
I am traveling, but like I joined.
Nice. Okay. You are all set. I am not going to spare you even if you are traveling. You are the summarizer here.
Do it. There will be some background noise, but I'll do it.
Okay. All right. So follicular lymphoma from classic grading to biological subgrouping. So basically, classic grading to biological subgrouping. Bapre. Oh, shit. Okay. So, okay, let's see what they are saying. Highlight. The family of follicular lymphoma encompasses follicular lymphoma in situ, B-cell neoplasm, pediatric type follicular lymphoma, and duodenal type follicular lymphoma. There are no significant updates on these three later entities. In contrast, the entity of follicular lymphoma has undergone significant revision. The vast majority of follicular lymphoma have, at least in part, a follicular growth pattern, are composed of centrocytes and centroblast, harbor T translocation A14-18, and are associated with IgH-BCL2. These are now termed as classic follicular lymphoma, which is set apart from the two related subgroups or subtypes, that is follicular large B-cell lymphoma and follicular lymphoma with uncommon features. So this is entirely new. So now those follicular lymphoma, that is vast majority, 85%, that has follicular growth pattern, first thing. And that has the BCL2, the centrocyte, centroblast, and translocation 14-18, IgH-BCL2 fusion. They are now classic follicular lymphoma. And then there is other subtypes, so for subgroups or what subtypes, and they are follicular large B-cell lymphoma and follicular B-cell lymphoma, follicular lymphoma with uncommon features. WHO Heme 5 grading, which is only pertinent to classic, so is no longer mandatory. So we used to have in our top lines follicular lymphoma low grade and follicular lymphoma high grade, grade 3, grade 3A, grade 3B. Apparently, we don't have to do it anymore. I mean, you can, your clinicians might still ask it, but it is no longer mandatory. And this decision was made after extensive. And actually, like if you would see your basically the low grade types are more classic types, and the high grade types they have separated out as follicular large B-cell lymphoma. So that's like more of what it will be encompassing. This decision was made after extensive discussions and evaluation of literature considering on reproducibility of grading and its questionable clinical significance for individual patients in the era of modern therapy. Poor reproducibility may result from various causes, including sampling, complete lymph node excision versus core needle biopsy, definition and recognition of the centroblast, and method of enumeration. Since grading of follicular lymphoma is based on enumeration of centroblast per Hyper field, one of the challenges is the lack of consistent definition of Hyper field using 40x microscope objective, where the size of microscopic field has changed over years, even at the same magnification. Lack of consensus regarding the morphological spectrum of centroblast using conventional methods of counting further negatively impacts the reproducibility. Clinical outcomes amongst the patients with follicular lymphoma grade 1, 2, and 3A seem not to be significantly different. Currently, patients are treated with similar protocols both in and outside clinical trials in many parts of the world. While attempts have been made to improve reproducibility through digital applications or by using IHC, such methods have not been compared to the patient outcome. Hence, it was deemed premature to include them in the Heme 5. Wow, okay. Taken together, for a histopathologic as well as clinical reasons, it was felt timely to make the grading of follicular lymphoma to be optional for the subtype of, optional in only the subtyping of classic follicular lymphoma. So it's not even mandatory, and if it is mandatory, it is only in the classic follicular lymphoma. I mean, anyways, they are the 3Bs, they are calling it large, follicular large. So the rare cases of grade 3A may show focal or extensive diffuse pattern. In WHO 4R, the recommended diagnosis in such category was DLBCL with follicular lymphoma, even though sheets of large cells are not often present. Currently, it is uncertain whether such cases should be better classified as CFL or DLBCL, and therefore treatment decisions in individual patients should not be based on pathology information alone, but rather be made on the multidisciplinary conference settings and await the research to define more objective criteria. The subtype of follicular large B-cell lymphoma largely equals 4R. Yeah, so that's what I was talking about. That makes sense. The subtype of follicular large B-cell lymphoma is basically grade 3B that we used to call, and remaining was done for the reasons for consistency throughout the classification. So our 3B is now follicular large B-cell lymphoma, and that makes sense because many of the people calling 3B, they used to just call it DLBCL or large B-cell lymphoma anyways. The newly introduced subtypes of UFL. What is U? Unclassified, right? What is U again? Uncommon features. So the newly introduced subtype of uncommon features of follicular lymphoma include two subsets that significantly diverge from the classic. One with blastoid or large centrocyte variant with cytological features, and the other with predominantly diffuse pattern. Okay. Follicular lymphoma with blastoid or large centrocyte cytological features more frequently display variant immunophenotypic and genotypic characteristics and may show inferior survival. They need to be distinguished from IRF4, large B-cell with IRF4. The follicular lymphoma with predominantly diffuse growth pattern occurs as a large tumor in the inguinal region and is associated with CD23 expression and absence of BCL2 and frequent STAT6 along with 1p36 deletion or TNF-RS14. So separating such cases from classic will support research to clarify disease biology. So basically, the uncommon features, UFL, that is having two subsets. First is the one that has large centrocyte variant or a blastoid variant. And then the other one, this is basically based on the cytological features, and they have variant immunophenotypic and genotypic characters as well. This has inferior survival. And then obviously this has to be differentiated with separately from the IRF4. And then there is another one, follicular lymphoma with predominantly diffuse growth pattern. This one is a separate entity and comes under uncommon features. And this is basically having features as it's a large tumor in the inguinal region associated with CD23 expression, absence of BCL2, frequent STAT6, and 1p636 or TNF-RS14. So that's that. Mantle cell lymphoma. So mantle cell lymphoma, the WHO Heme 5 subgroups the mantle cell neoplasia into 3 different categories as individual chapters. So in situ mantle cell neoplasm is rare and typically incidental finding. It represents colonization of mantle zones of lymphoid follicles by B cells that are carrying the IGH-CCND1 fusion, leading to cyclin D1 overexpression. The IGH-CCND1 fusion associated with translocation 1418 is genetic hallmark of mantle cell lymphoma, which is present in more than 95% of the cases. Occasionally, IgK or Ig lambda serve as CCND1 translocation partners. In occasional cases of MCL that strongly express cyclin D1 but does not show CCND1 rearrangement by FISH, genomic studies have revealed cryptic rearrangements of IgK, kappa, or lambda enhancers by CCND1. And so, again, so this is by definition the mantle cell lymphoma, IGH CCND1 fusion associated with 1114 genetic hallmark. And then in small subset of MCL, negative cyclin D1 expression, negative for cyclin D1 expression, the CCND1 rearrangement, that is cyclin D1's negative mantle cell lymphoma subtype, CCND2, CCND3, CCNE rearrangement have been identified as alternative mechanisms of cycle dysregulation. In recent years, the median overall survival of patients with mantle cell has dramatically increased due to improved therapies. Hence, the identification of prognostic subgroups have become highly relevant. Widely available and best established biomarkers for high-risk mantle cell include cytomorphologic, for example, pleomorphic or blastoid appearance, high Ki67, P53, and TP53 mutations. So these are high-risk MCL now. Basically 4 things. First is the blastoid, pleomorphic. Second is high Ki67. Third is P53 and TP53 expression and TP53 mutation. Now the leukemic non-nodal that we used to call non-nodal MCL is characterized by involvement of blood, bone marrow and spleen, little or no lymphadenopathy, mostly asymptomatic presentation, and a better clinical outcome. Biologically, non-nodal mantle cell lymphoma differs from mantle cell lymphoma. Why? Because there will be a lack of SOX11. So, and then low Ki67 index, frequently lacking CD5 expression, differences in usage of IGHV gene segments with biased usage of IGHV1 gene, 18 gene, together with high somatic hypermutation load and fewer genetic alterations and infrequent genomic complexity. So basically, we used to have another paragraph on leukemic non-nodal mantle cell lymphoma in WHO. And it was more CLL-like, if you guys remember. It was more leukemic. It was not having lymphadenopathy. It was more in the blood and bone marrow. And in fact, it was having like CD23 or something as well, which was more CLL type. It was lacking SOX11. It was like different from the mantle cell lymphoma entirely. So now they are telling the same thing here. So it will lack the SOX11. It will have low Ki67 index. They will be lacking frequent CD5 expression. Differences in usage of IGHV segments with biased usage of IGHV18, high somatic hypermutation load, few genetic alteration, infrequent genomic complexity. And this has a better clinical outcome given that everything going on with this thing. So that's that. Now, high-grade transformation steps forth. For the first time, Heme 5 now includes a section with description of high-grade transformation of indolent B-cell lymphomas, including the summary of incidence of known and driver genes. So basically, large B-cell lymphomas, new names and new umbrellas. The families of large B-cell lymphoma comprises a wide spectrum of tumors. Although these are generally composed of medium-sized to large cells with round to oval nuclei and vesicular chromatin, cases with intermediate-sized and blastoid cells may also meet the criteria. These require delineation from morphologically similar entities such as blastoid variant of mantle cell and lymphoblastic leukemia. Now, DLBCL NOS. represents the most common category and is defined by large cell morphology as above, mature B cell phenotype, and lack of criteria defining specific large B cell lymphoma entities. The lymphomas encompassed with DLBCL NOS are morphologically and molecularly heterogeneous. Since most DLBCL NOS broadly recapitulate the differentiation and maturation mechanisms active in the germinal centers, two main subtypes previously defined in 4R continue to be recognized. So now the GCB and ABC are still there. The germinal center B cell subtype has the genes expression profile related to the GC of origin and is enriched by IgH BCL2 fusion due to 1418 and mutations of genes instrumental for GC development. GC dark zone, light zone transitions, microenvironment interactions such as EZH2 and the others. The activated B cell subtype derives from the cells of GC exit or post GC origin with either germinal center exit or early plasmablastic phenotype. Germinal center exit or early plasma. So this is basically two types of ABC. It is characterized by dependence on BCR signaling and NFKB, kappa B activities. It is and is negative for most GC markers, will express MUM1 in fact, the IRF4 MUM1. So basically the ABC type was BCL2 and 1418 and the GCB type was BCL2 and 1418 and the ABC type is IRF4 MUM1. It is enriched for BCR pathways mutations such as in MYD88, CD79B, PIM1, as well as genetic changes that block the B cell differentiation program, such as BCL6 rearrangement, PDRM1, BLIMP1. It is recommended to continue the rendering the GCB ABC distinction, although it has become apparent that the clinical impact of what is COO again? COO stratification is relatively limited outside clinical trials. Oh, cell of origin. Okay, stratification. Okay. Although IHC algorithms obviously do not recognize the unclassified GEP category have concordance issues with GEP, they are widely used in routine practice. Recent data from next generation sequencing studies have illustrated heterogeneous molecular landscape of DLBCL NOS with around 150 genetic drivers that are recurrently mutated in DLBCL, which mean approximately 8% of these genes mutated per patient. Interestingly, in spite of the use of various sequencing approaches and clustering algorithms, the genetic landscape of DLBCL NOS can be used for subclassification with broad concordance, suggesting that underlying disease biology can be captured by mutational analysis. Some of the genetic subgroups harbor a mutational profile that in part overlaps with those of follicular or marginal zone, suggesting either transformation from the these low grade, or a common path in their early pathogenesis. However, no unifying concept was for proposed clusters, and the significance of their genetic drivers have been established for so far. There was a, we didn't do this, but they are not yet finished with this. But let's I am interested in this now. So actually, let's finish this. Make our life more complicated. Okay. So where were we? Okay. However, no unifying concept for proposed clusters and the significance of their genetic drivers have been established so far, precluding the definition of a unified genetic framework of DLBCL NOS at the present time. Moreover, the impact of these genetic clusters on outcome as basis of for targeted treatment is currently unclear and awaits evidence from clinical trials. Therefore, it was considered premature to introduce such molecular classifications in the Heme5. Thank you. WHO Heme5 recognizes 17 subspecific entities as large B cell lymphoma other than DLBCL NOS. So that's in table 1 and figure 3. For most of these entities, biological concept and diagnostic strategies have remained largely unchanged compared with 4R. However, the names of some entities have been modified for reasons of consistency, from DLBCL to large B cell lymphoma, acknowledging the fact that a diffuse growth pattern is either not apparent or present or cannot be assessed in some entities. For example, in fibrin-associated large B-cell lymphomas or fluid overload associated. The 4R entity of high-grade B-cell lymphoma with dual MYC BCL2 and BCL6 has conceptually reframed and reassigned in recognition to the variable morphologies but homogeneous dark zone biologic features and gene expression characteristics. The WHO Heme5 renames it as diffuse large B-cell lymphoma or / high-grade lymphoma with MYC and BCL2. So DLBCL / HBCL, HGBL, MYC / BCL2 to encompass tumors defined by the presence of dual MYC and BCL2 that may be composed of large or intermediate blastoid cells. So now this is the new nomenclature. And hence the primary morphologic categorization of the neoplasm can be maintained after determining the genetic constitution. This group of cases form heterogeneous entity with exclusive GC gene expression profiles, a close pathogenetic relationship to follicular lymphoma, and molecular GC-like BLBCL subsets. Okay. In addition, so basically, close pathogenetic relationship to follicular, it has BCL2 anyways, and molecular GC-like DLBCL subsets. In addition, gene expression signatures associated with DLBCL high-grade MYC BCL2 significantly overlaps with those of Burkitt. In contrast, and obviously, like it is more follicular plus Burkitt, MYC plus BCL2. In contrast, lymphoid neoplasm with dual MYC and BCL6 represent more diverse spectrum with variable gene expression profiles and mutation spectra, markedly differing from MYC BCL2. Hence, they have been excluded from the MYC BCL2 and now classified under DLBCL NOS or high-grade B-cell NOS according to the cytological features. Okay, wait a second.
Can you repeat the last one? I didn't get that.
Yeah, I'm trying to see. I was under impression when I was reading the thingy over here that they removed the large B-cell lymphoma NOS category. Is that not correct? Chronic inflammation, diffuse large B-cell lymphoma, large B-cell NOS, RF4. Okay, EBV positive. Oh, they removed. Oh, there is high-grade B-cell lymphoma. Okay. Okay, sorry. Okay. So let's clarify the last thing that you were mentioning. Okay. So they now, first thing, they removed the BCL6 from this because it was having an entire different genetic profile and mutational spectra. So now BCL6 is no longer there. BCL6, those with BCL6 mutations and MYC BCL6 or BCL2 BCL6 are now classified as subtype of DLBCL NOS or high-grade BCL lymphoma NOS according to their cytomorphological features. So, I mean, if it looks like DLBCL, then just classify those BCL6 categories into still DLBCL NOS. And if it looks like more high-grade NOS and it cannot be classified as DLBCL, then just call it high-grade NOS. Now coming to this Burkitt-like lymphoma with 11q, previously it was called as Burkitt-like lymphoma with 11q in forearm. Now they are calling it high-grade B-cell lymphoma with 11q. So we'll read why. It is an aggressive and MYC rearrangement negative mature B-cell lymphoma with morphologic similar to Burkitt or with an intermediate or blastoid appearance, immunophenotype being CD10 positive. So CD10 positive, BCL6 positive, BCL2 negative, gene expression profile similar to Burkitt's, and characteristic chromosome 11q gain or loss. The losses, so basically morphologic features of Burkitt, CD10 positive, BCL6 positive, BCL2 positive, negative, and gene expression profiling similar to Burkitt's characteristic, 11q gain or loss. The losses in 11q quarter, are more specific to this entity than the centromeric gains, but rarely might be substituted by copy number neutral losses of heterozygosity. More recent studies have also confirmed that the mutational spectrum, besides the pattern of genomic imbalances, is different from Burkitt lymphoma and more similar to DLBCL of GCB type. That's why they have changed in the nomenclature. So it makes more sense to not call it Burkitt-like. Of note, genomic alterations affecting the IDC TCF3 complex, one of the molecular hallmarks of Burkitt's, are only rarely, if at all, seen in high-grade B cell of 11q. Okay. IDC TSCF3 was hallmark of Burkitt. I am learning this now. Okay. And cases of B cell lymphoma with Burkitt-like appearance that lack MYC rearrangement, therefore, should be tested for 11q gain or loss pattern. It should be noted that morphological spectrum of high-grade B cell lymphoma 11q, as defined by specific 11q gain or loss pattern, is more restricted than that of DLBCL high-grade B cell lymphoma with MYC and BCL2. So remember that this entity is still morphologically looking Burkitt-like, and morphologically it will look different than that of high-grade MYC BCL2. So that's something that they want to emphasize. Large B cell lymphoma of immune privilege. So that our PTLD things. No, yeah, that's the CNS things, not PTLD. Immune privileged sites. So those are the testes, CNS, and the others. So basically, is a new umbrella. Yeah.
Can we cover that figure 4 first, because that is just summarizing what we have read about large B cell lymphomas?
That's a good idea. Okay, let's do that. So figure 4, and also there was another one here. So, okay, the 4R versus 5. Primary DLBCL of CNS. Any immune deficiency setting, especially EBV associated, now it is either immune deficiency dysregulation associated lymphoma or LBCL of immune privileged site. So, okay, we'll read more about when we were going to read the CNS thing. DLBCL NOS, any immune deficiency setting, you're going to call it. So any immune deficiency setting, you're going to call it immunodeficiency associated, dysregulation associated. Okay. If in the absence of immunodeficiency setting, if it is in the immune privileged site, as in testis or vitreoretina, you're going to call it LBCL of immune privileged site. And DLBCL NOS, again, the DLBCL NOS will still be there. And MYC BCL2, BCL6, now the MYC and BCL2 and BCL6 will be encompassed by DLBCL NOS. MYC, BCL2 and BCL6R or G will be DLBCL, HBCL with MYC and BCL2. So this is even more complicated. There is BCL2G and there is BCL2R.
It seems like it's a triple hit, goes to DLBCL and OS. Am I correct?
No. So no, there is a BCL2G and there is a BCL2R. The BCL2G, so basically if you see the MYC-R and BCL6R remains the same. But the difference in these two are there is BCL2G and BCL2R. The BCL2 gene is going to DLBCL. The BCL2R is going into MYC BCL2. Does that make sense? And then
in the bottom they described G as germline. So they are meaning that this BCL2 rearrangement is not there and BCL6 rearrangement is there. So in that case, you will call it as DLBCL and NOS.
Okay. And what is R?
R is for rearrangement and G is for just germline configuration. That's they have given at the bottom.
They could have made it
Yeah,
easier.
they have
Okay.
mentioned it at the footnote.
Yeah,
Yeah.
at the bottom
Oh.
of the.
Okay. So basically, MYC and BCL2 rearrangement. If it has MYC and BCL2, then it is in here, despite if it has BCL6, whatever the BCL6 thing. But if it does not have BCL2 rearrangement and only MYC and BCL6, it is DLBCL NOS. And then the BCL2 rearrangement and or BCL6 R or G and or okay, rare B-cell lymphomas. So what is the third category?
Looks like below they have mentioned about the rare B-cell lymphomas.
Okay, let's read what they are saying. Summary of relationship between large B-cell define. Okay, rare B-cell lymphomas refer to those fulfilling definitions of specific clinicopathologic entities while incidentally bearing MYC and BCL2 rearrangements. Okay, example are fluid overload associated large B-cell lymphomas, rare follicular lymphomas. R is rearrangement and G is germline. Okay, so those rare entities like fluid overload or rare follicular, if they have MYC and BCL2 rearrangement, but they are those rare entities, there will be those rare B-cell lymphomas that will be encompassing that. All right, so that is clear. I mean, that we were reading is clear. There, if it is MYC and BCL2 rearranged, even if it is BCL6 rearranged or germline, regardless of that, it will be this category, MYC and BCL2. If it is no BCL2 rearrangement and BCL6 rearrangement and MYC, then it is DLBCL NOS. And then the rare B-cell subtypes can have the BCL2 and MYC, but they will be still categorized as rare B-cell subtypes. Now coming to B-cell lymphoma, unclassifiable, that was the mediastinal gray zone. So features intermediate between DLBCL and CHL. So they are now calling it mediastinal gray zone. If it is having an extra mediastinal location, so this mediastinal, because it has the mediastinal name, if it is extra mediastinal, go for DLBCL NOS. We used to have these categories where there were extra mediastinal places and we were still calling it this entity. But if it is extra mediastinal, we are going to call it DLBCL. Again, any immune deficiency setting, just go for immune deficiency dysregulation associated lymphoma. So anywhere from here, the primary DLBCL of CNS, DLBCL NOS, B-cell lymphoma unclassifiable, any of these with IDD setting, we are calling it immune deficiency associated. Okay. Thank you for making this. Okay. Now, this one. Diffuse large B-cell lymphoma. So germline and rearranged. MYC. Agar MYC rearranged, if it is MYC rearranged, let's see germline first. So if it is BCL2 anything or BCL6 anything, but there is no MYC, then it is diffuse large B-cell lymphoma. Now coming to MYC, there are various things that can happen with MYC. MYC with BCL2 germline and BCL6 anything. That means that BCL2 is not rearranged, then it is NOS. If BCL2 is rearranged, regardless of BCL6, then it is the dual category. If it is IGH MYC, BCL2 and BCL6, just the MYC, then it is Burkitt's. IGH MYC is Burkitt's. And then fourth is MYC rearranged, and then BCL6 rearranged or germline, BCL2 germline, that's high grade B cell.
Yeah, I think it's what we have read that that there was a confusion. So when the MYC is rearranged in this BCL6 is rearranged. In that case, if the morphology is of DLBCL-NOS, we will call it DLBCL-NOS. Otherwise, we will call it HGBL-NOS. I think that's
right.
what.
Yeah, that's right. That's right. Yeah, that makes sense. Yes. Okay. And then Burkitt's and high-grade B-cell lymphoma. Burkitt's, MYC R. So IGH MYC, then call it Burkitt's. MYC is germline, and there is BCL2 rearrangement or BCL6 rearrangement or anything. If MYC is germline, then call it high-grade B-cell lymphoma. If there is 11q gain or loss, and MYC is germline, then call it high-grade B-cell lymphoma with 11q. Kill me now. Okay. Is that clear, or someone needs any more explanation or any more? They want to give any more explanation?
I think, it just takes some time to kind of things make sense, it's just we need to kind of review it later on, maybe next session a little bit.
Yeah, that's why I was saying, Iman, that if like you are going to review the 4R, it will really not make more sense at this time, because all the many things have changed, and that will create only more confusion between Heme 5. So if you are learning the Heme 5 de novo, then it will make much more sense, because now you know the de novo, the Heme 5, and you don't know the 4R.
Yeah, you're right. Yeah.
So is the new one out yet?
No, only the article is out. The new one is going to be out in July. They said online only in their website, IARC website. And the paper copy is going to take some time till December or something. But the online version is going to be there, and that is going to be like a beta version that might have changes in the final copy. They are just rolling it out as beta to see how it is doing.
Okay.
Okay, any questions here?
I think this is basically like you need for this category, like if we understand one thing, that to call it BCL or high-grade B lymphoma with MYC and BCL2, you need both MYC rearrangement and BCL2 rearrangement.
Right.
If you have both, then it will go in that category. If you have either one, that you like, if it is just MYC rearranged, but BCL2 is not rearranged, then you need to see which category it would go into. Like if it is MYC rearranged, but not like BCL2 is not rearranged, BCL6 is arranged, then it will go in DLBCL-NOS category. If there is like Burkitt-like rearrangement with IG, then it would go in Burkitt lymphoma category. Then same for like if it is just BCL2 rearrangement, but the MYC is not, then like it will go into those kind of categories. I think if we understand that, then we can maybe put into one of those categories.
Right.
But it is confusing.
This diagram in itself is creating, like my khichdi in my mind. Okay. That's fine. Making it simple. Let's make it simple for us. BCL2.
I think just like because there was in MD Anderson discussions, they were saying that actually they don't emphasize anymore on germinal center and non-germinal center. There are several new studies, and one of them was published in New England, that basically these are categorizing based on the molecular profile of the diffuse large B cell. Basically, that's how they're going, and that's why it's like mixed up. So it's,
but they are saying that they are still categorizing as GCB ABC.
Yeah, it is, but it's some of them, they're not very excited about it. Still it's in there, but I think some people, they were talking, they were not very excited about it, and they want this completely go toward like a molecular categorizing. But I think this is a compromise of these two main schools.
Yeah. Okay, so go ahead.
Yeah, so I think if MYC is negative, then you call it diffuse large B cell. But if MYC is rearranged, then it becomes DLBL high grade with MYC and BCL2.
So there are two things if MYC is negative. First, MYC is negative and has BCL2 / anything, BCL6, anything, then it is DLBCL NOS.
Yes.
If MYC is negative. The other thing is if MYC is negative, and there are other entities which will be still that will be not morphologically DLBCL. They will be high grade B cell lymphoma NOS. And then third is if it has 11q, then it will be high grade B cell with 11q. Right? So MYC germline can be both types, DLBCL and high grade B cell. And if 11q present, then 11q. And then coming to MYC rearranged, if it is IGH MYC, then just IGH MYC, then Burkitt. If it is MYC with BCL2, then those are the dual category. If it is MYC with BCL6, then it is DLBCL NOS. And there will be other categories in which there will be MYC BCL6 and or BCL2 plus BCL6, then it will be high grade B cell. Does that make sense?
Mm-hmm. Yeah, that makes sense.
Okay.
I have a question.
Yeah.
This is all based on the molecular. So in a real case, do we require to perform the IHC on all the cases, or we can just go ahead and do the molecular?
No, all the DLBCL cases, you do perform the BCL2, MUM1 and BCL6. There's like MYC, you may or may not perform based on if it is Burkitt-like. But you, I mean, we used to perform MYC in DLBCL in MSK, but I saw that many people don't do MYC in usual DLBCL. But yeah, you have to do still the IHC, and despite that, it is more molecular now. But still, till the molecular and everything, and still the IHC is still intact. You still have to do it. And in any case, BCL6, MUM1, and BCL2 come into your ABC and GCB classification of Hans algorithm. So in order to subclassify it as GCB and ABC, those immunophenotype expression patterns will still be important.
Yeah, makes sense. Mm-hmm. And so if we are, suppose example, we order the genetics and we are waiting on the results, at that point, it is really difficult to say anything. We can only just say that it's like B-cell lymphoma, right?
Yeah, so if it looks like DLBCL, just call it DLBCL. If it looks like, don't label it as NOS or anything else. If it looks like, see, they have clearly mentioned morphology diagnosis, genetic changes, and the genetic diagnosis. So morphology diagnosis is three type of diagnosis. First is DLBCL. If it does not morphologically classify as DLBCL, then call it high-grade B-cell lymphoma. And the third one will be Burkitt lymphoma. So again, Burkitt lymphoma, morphological versus the molecular is the gold standard. So still, I mean, those that have combined features of DLBCL and Burkitt, and you cannot tell, then just lump it into high-grade B-cell lymphoma.
Can I add something here?
Yeah.
Yeah, so these IHC that we are talking about, so many a time these IHCs are done because just to see the expression. So if MYC is like most of these rearrangements, because they are involving one of the IG genes, so they will lead to overexpression. To like the MYC will be overexpressed, BCL2 will be overexpressed, likewise. So when we are doing IHC, we will see the overexpression. So if we are not getting MYC overexpression, then there is no point of going for the fish and everything for this MYC. So again, when it can be overexpressed without the rearrangement, but it's very rare to be overexpressed.
According to what we are doing over here, all the high-grade B-cell lymphomas, we are going for all of these. Like, despite if it is DLBCL, Burkitt, or high-grade, we are going for all of these.
Yeah, I was talking about the places like ours where the resources are limited. In that case, first they do this IHC and then they will decide, okay, the MYC is overexpressed, then it makes sense to do the fish for this.
Yeah. Yeah, because we over here, we have a high-grade B-cell lymphoma panel that we send outside. And that high-grade lymphoma panel has multiple things, which includes all of these. So any high-grade lymphoma, we are going for all of this panel.
Yeah, even in that case, they first do MIC. If MIC is not rearranged, then the classification will definitely go into this NOS, either DLBCL NOS or HGBL NOS. So they will not do the remaining two fish for that.
Is that what is happening in the other institutions? Do you guys know?
At my institute, we for the any DLBCL, we go ahead and do the fish for the large B-cell lymphoma, and previously we were doing the reflex panel, but now we are doing the complete panel. So we do all three, like BCL2 and BCL6. Previously we were doing reflex. If first one is positive, then yeah, okay.
Right. Yeah. So that's what our institution is doing, and multiple institutes that I have worked in, all of the institutes are doing the same. So I think there's a change of what we used to do traditionally. Okay. Any other important considerations? Is this let's see, read the CNS type and fluid overload type. Mediastinal, KHHV, RAR.
Could be summarized to
yeah, let's do you want to summarize all of them together, or let's summarize them piecemeal?
I can summarize from like marginal zone.
Yeah, let's summarize it till now because our brains have been fried. Okay. Okay, let's read marginal.
So marginal zone, they have like three categories that remain as such. Like three main categories are extranodal marginal zone, nodal marginal zone, pediatric nodal marginal zone, actually four, and primary cutaneous marginal zone. So initially we had like extranodal and nodal marginal zone. Now this pediatric nodal marginal zone, this has been made a separate category, and then primary cutaneous marginal zone lymphoma, this has also been made a separate entity. So these are the four broad categories under marginal zone lymphoma. All of these have similar overlapping, like as we know, overlapping histological and immunotypic feature, which is like negative for 5 and 10, and they have plasmacytic differentiations. Then as we would, as the top line says of the marginal, that the cytogenetical mutational profiles, they differ by anatomic sites. So like when we are talking about nodal marginal zone lymphomas, there are some specific, so first of all, trisomy of 3 and 18. They are present in all of marginal zone lymphomas, trisomy of 3 and 18. Then for the nodal ones, they have gain of chromosome 2p and 6p. These are the gain. For the P ones, like gain has gain with P, 2p and 6p, and there is loss of 1p and 6q in the nodal marginal zone lymphoma. But these are for nodal. Then going for the important extranodal ones, like the gastric and the pulmonary ones. I'm skipping the ones like which are, so the gastric and pulmonary ones, these were like, I thought were very important during boards, like translocation 1118, which is BIR-C3 and MALT1. These are present in gastric and pulmonary extranodal marginal zone lymphomas. Then they have given very specific which extranodal, these, I'm not going to go into the details of all that. I think we can read all these, or if you want, I can read. Then for the follicular lymphoma, follicular lymphoma, initially we had like the classic grading based on the number of the centroblasts. But now the follicular lymphoma have been divided into three broad categories. We'll go into that, which is classical follicular lymphoma, then follicular large B-cell lymphoma, and follicular lymphoma with uncommon features. For the classical follicular lymphomas, it has like those main follicular growth, translocation 11, 14, 14, 18, and centroblastic differentiation. Then now the important thing is the grading, which was based on centroblastic number. It has been made optional, and this is mainly for the classical follicular lymphoma, not with the large cell or with the uncommon feature type. So grading, it is optional now, and it is only for classical follicular lymphoma. Then the second type is follicular lymphoma with large cells, which was here. This is basically follicular lymphoma grade 3B, which has mainly all large cells. So this has subtype is now, this grade 3B is now called follicular large B cell lymphoma. And then the third is follicular lymphoma with uncommon features. So this follicular lymphoma with uncommon features, it has two things. Uncommon could be either the morphology of the cells, that is uncommon morphology is blastoid morphology or large centrocyte morphology. And important thing about them is they need to be differentiated from large B-cell lymphoma with IRF4 rearrangement. So that was about the cell morphology. And the second uncommon pattern is that they have a although it is follicular, but they have a predominantly diffuse growth pattern. And this occurs in inguinal region. And it has uncommon common features like CD23 expression. It has no 14-18 translocation, but it has STAT6 mutation and 1p36 deletion. So important features for this are like what is expressed. They are expressing CD23, STAT6, and there is no IGH BCL2, and they have a 1p36 deletion or this TNSRF14 mutation. Then coming to, so this was about follicular, then coming to mental cell lymphoma, they have tried to improve risk stratification. We know that initially mental cell was divided into mental cell and in situ mental cell, and then some variants of mental cell. In situ was like, you just have the translocation. Morphologically, it is not that clear, but you have the translocation. And then the hallmark in general of mental cell, as we know, is IGH, CCND fusion, translocation 1114. So usually this translocation 1114, it is between IGH, immunoglobulin heavy chain, and CCND1, that is cyclin D1. And this is present in 95% of the cases. But they said in occasional cases, in the remaining 5%, instead of IGH, you could have like light chain rearrangements, like that is kappa or lambda, or instead of CCND1, you can have translocation with CCND2, 3, or like CCNE rearrangement. Then they have also established biomarkers for high-risk mental cell lymphoma, which include basically anything related to high risk, what would be high risk, like pleomorphic appearance, like morphology. First is morphology, that is pleomorphic or blastoid morphology. Then a high proliferation, that is high Ki67. Then P53, we know usually it's high grade, so it's P53 or TP53 expression or TP53 mutation. The next in mental cell is non-nodal, which was initially like leukemic kind of thing. Non-nodal mental cell is, although it's in previous it was like leukemic, but although it is leukemic, but they still had a better clinical outcome. And their features wise, it is different from classical mental by lack of SOX11 expression, although they are like and they have low Ki67. So no CD5, no SOX11. Low Ki67, and for IGH, they use a specific IGH, which is IGH variant 1 to 18, and they have high somatic hypermutation. Since it is associated with better clinical outcomes, so I remember it is like fewer genetic alterations and like infrequent complexity. Then now there is high-grade transformation or large B-cell lymphomas. So first category is large B, I'm coming to DLBCL NOS. So DLBCL NOS is basically defined by large B-cell morphology, and you need a diffuse, like it should be diffuse. And now this whole large B-cell category, as they were describing in the table, is like DLBCL NOS and 17 other subtypes of these large B-cell lymphomas. So for DLBCL, like we know germinal center type and activated type. So for germinal center type, they would be the cell of origin would be germinal center, and like it's pretty much like follicular, like they have IGH BCL2 fusion. And for the activated, it is non-germinal. So basically it has exited from the germinal center. So their cell of origin will be the germinal center exit, or like after exiting, they change to plasma cells. So like early plasmablastic phenotype. And they are positive for MUM1 and they are negative for germ cell markers. Okay, so let's before going into, let's do these two tables. Can we go to the other table first? Okay, so let's on the left side they have written morphology, like primary DLBCL for the fourth grade, like fourth WHO, primary DLBCL of CNS, DLBCL NOS, and then high grade BCL with MYC and BCL2 or BCL6 rearrangement, and BCL lymphoma unclassifiable with features between DLBCL and CHL. So for the CNS, primary DLBCL of CNS, they have either, if So one is in new category, we have immune deficiency associated lymphomas. So anytime you have any kind thing associated with immune deficiency, just put it into this category, which is basically which earlier like primary DLBCL of CNS associated with IDD, or DLBCL NOS associated with IDD, or like B cell unclassifiable associated with IDD. So any of these three, if it is associated with immunodeficiency, put into this side. Then new entities, LBCL of immune privileged sites. So under this comes, now instead of calling it primary, if it is lymphoma of CNS, but it is not associated with immunodeficiency, or if it is DLBCL of testis and vitreoretina, since these are immune privileged sites, you just call it LBCL of immune privileged sites. Then DLBCL NOS, it remains as such if it is like not going into any of these categories. Then we had HGBL with MYC and BCL2 and or BCL6 rearrangement. Now this is put into three categories. Either like you call them, if it is MYC, so like to call it second category, which is DLB amongst these three, the second one, which is DLBCL or high grade B lymphoma with MYC and BCL2 rearrangement. You need rearrangement for both MYC and BCL2. So MYC and BCL2 are important. BCL6 can be rearranged or germline, whatever, but you need both MYC and BCL2. If it, then you call it MYC and BCL2 rearranged. If it is either showing like just MYC rearrangement or just BCL2, then you call it like DLBCL NOS. And if it is showing both rearrangement, that is MYC is rearranged, BCL2 is rearranged, but if it is showing morphology or features of one of those rare B cell lymphoma, which we'll read further, that is fibrin associated or fluid associated lymphomas, then it will go into those rare B cell lymphoma categories. And though for the features, for the lymphomas which were unclassifiable with features intermediate between DLBCL and CHL, they have been put into mediastinal gray zone lymphoma category now. And if they are primarily extramediastinal, then they will be put into DLBCL NOS. And for this table, so this table, let's try to break it. So as Akanksha was saying, like we have three morphologies: diffuse large B cell lymphomas, Burkitt lymphoma, and high grade B cell lymphomas. So for you either see like, so we are mainly focusing on MYC, starting with the MYC and then going into the BCL2, BCL6 and other genes. So say for the diffuse, I'm going by morphology category for DLBCL. So if either like your MYC is germline or MYC is rearranged. If it is germline, but you have BCL2 rearranged, as we were saying earlier, we need both to call it associated with MYC and BCL2 rearranged. If it is, we here just have BCL2 rearranged, but MYC is germline. So it will just go into DLBCL NOS. So if it is MYC rearranged, BCL2 germline, BCL6 rearranged, again, it's going into, now MYC is rearranged, but BCL2 is germline. BCL2 is not rearranged, but BCL6 is rearranged. That doesn't matter. BCL2 is not rearranged. So it will also go into DLBCL NOS category. Now with MYC rearrangement, you have like BCL2 rearrangement and BCL6 rearrangement. So this will go into MYC and BCL2 category. Then if MYC is rearranged and it has a translocation with IgH, immunoglobulin IG, so then it will go into Burkitt lymphoma category. Then if MYC is rearranged, but BCL2 is not, and the morphology wise it is high grade, then it will go into high grade B cell lymphoma NOS. Then if morphology, then comes if MYC is germline and BCL2 is rearranged and morphology wise it is high grade B cell lymphoma, then again it will go into high grade B cell lymphoma. And then if there is the morphology is high grade B cell lymphoma morphology, but there is 11q gain or loss, then it will go into high grade B cell lymphoma with 11q gain or loss. So like let's try once again. So if just like remember, like for high grade B cell with MYC and BCL2, you need rearrangement for both MYC and BCL2. Then decide the morphology. If it is DLBCL morphology, then and you are seeing either MYC rearrangement or BCL2 rearrangement, but not seeing both, then you will call it DLBCL NOS. Versus if it is high grade morphology and same, if you're seeing MYC or BCL2 rearrangement, but not both, you call it HGBL NOS. Then if it is MYC with IG translocation, you call it Burkitt lymphoma. And if it is high grade morphology with 11q gain or loss, you call it high grade B cell lymphoma with 11q gain or loss.
think that's it.
That was actually perfect. Very good. Okay, next.
Okay. I think it pretty much covers this.
Yeah, it does. Okay.
Okay.
My brain is fried now. And let's just stop here. We'll continue from the immune privileged sites. Is that the one? I agreed. Mediastinal so nice. Is that fluid overload? Yeah, immune privileged sites. So we are going to continue from immune privileged sites, most likely tomorrow, and then we'll try to see. Nidhi, are you coming tomorrow?
I'm not sure. I'll play it by the ear.
Okay. Yeah. Anyways, we'll just quickly summarize. We didn't do much of the extra today, but we did do a lot of extra today too. So we'll quickly summarize the extra that we did today, and then we'll continue doing the immune privileged sites and so forth. All right.
So where are all these articles? Are they in the group?
They're in the group, and they're also available as open access. So if you just Google WHO classification for 2022, then you will get it. That's why we are able to do it, because they are open access. I mean, the ICC classifications, I'm not sure if we'll be able to do it without permission. But this one, this is an open access, so we are okay.
The ICC lymphoid is also open access, so maybe we can.
Yeah, and eventually they will probably make the myeloid open access too, so we can do it. Yeah. Any other questions? Anything that you want to ask? Add? Even if you want to.
Thank you.
Sure. Even if you want to show your frustration in being heme, and being regret of joining the heme fellowship who have joined yesterday.
No, it's fun. Still
fun.
Benefits, challenging.
Yeah. All right, then. Okay.
So tomorrow, same time?
Same time, yes.
All right. Thank you.
All right.
Okay. Thank you, everybody.
Thank you so much. Thank you.
Bye.
Have a great day.